Welcome everyone to today's webinar, Can Endoscopic Spine Surgery be Profitable in the ASC? Key Considerations from an Orthopedic Surgeon. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through just a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's speaker, Dr. Tony Mork, founder of Endoscopic Spine Academy. Dr. Mork has 23 years experience in minimally invasive endoscopic spine surgery. He's published peer-reviewed articles on the subject and is a practice management expert who mentors physicians on moving to concierge and cash-based medical practices. Dr. Mork, thank you for being here today. I'll now turn the floor over to you.
Thank you very much and good morning. I think that I'm here with my strategic partner, Pam, as well as Darren Fisher, who is an expert in ASC management. So we have some pretty good support here. I think that one of the big stumbling blocks of adopting endoscopic spine surgery into one's practice is on the doctor side, just being maybe enthusiastic but not knowing exactly how to integrate it. And then on the ASC side, is integration of endoscopic surgery into the ASC profitable? So today, I'd like to talk about the question, can endoscopic spine surgery be profitable in the ASC? And the answer is absolutely. But success is dependent on two things. How much money is going to be coming in and how much money is going to be going out. So let's talk about the factors that help to determine this. So when the ASC administrator is about to do a return on investment analysis, the ASC administrator needs to consider a balance of a couple different things. One is the volume or the number of procedures being performed. Two is the reimbursement being received. And three, the operating costs involved. Okay, let's talk a little bit more about how much money is going to be coming in. Well, the ASC administrator is going to be interested in, one, the CPT codes for a given procedure, and two, the volume for helping to calculate the cost benefit. So for the doctors, on the surgeon side, you can help the administrator with determining these things, the CPT codes and volume, to increase their success or your success for acceptance of endoscopic spine surgery in the ASC. Well, let's talk a little bit about CPT codes. So the CPT codes determine the reimbursement for a case, and they're specific for that particular procedure, while ICD-10 codes are specific for prior authorization of the procedure. So they're not really the same at all. What else can we say about CPT codes? Well, they are much affected by your insurance mix. So another thing to discuss with the ASC administrator is your particular insurance mix. So if it's Blues or Medicare, or depending exactly what it is, you really want to have this, in hand when you approach the ASC. The second thing to understand is that the policy is both state and patient specific. So even though Aetna may operate in several different states, the policies for each state can vary, as well as for the patients. So this is really important to understand. So you have to look carefully at what the insurance company states for your particular location, as well as the particular thing that you're recommending for a patient. A little comment about HMOs is that they can be iffy, meaning that on the West Coast, it's probably a no-go. In the Midwest, might be okay. On the East Coast, might even approach PPO benefits. So where the HMO is located can have a big difference on the effect of reimbursement for the procedure. The other thing that you have to really think about is that the more accurately you can describe your CPT codes, the better that, the more likely that the ASC can adopt an endoscopic spine practice. Let's talk about a little bit more specific kind of an example here. So a CPT code for facet debridement 22102 in the lumbar spine, it's covered. And so in large part, Medicare helps to determine what's going to be covered because all the insurance carriers seem to follow Medicare. So it is covered on an ASC or outpatient basis. And so the next thing you have to look at then is what's the patient policy? Do they have to have physical therapy? For how long? How about the injections? Did they have to have, how many blocks did they have to have with so much success in order to authorize the procedure? So you have to kind of go through this algorithm of discovering whether it's covered or not, and a good place to look is Medicare. And then the second is, what's the policy of the insurance company for that particular patient in that particular state? And the next thing that the ASC administrator is going to be talking about is volume. So the total cases the surgeons will perform in the ASC. And there's a couple different aspects to this. Is it just going to be you who can use the equipment, or can the equipment be used by more than one doctor or a few doctors? This helps the ASC to determine the volume. And that is going to be super important. One thing also I would just mention is that for endoscopic spine equipment, if you're planning to do cases back to back, you're going to need two trays because there's about a 40 to 50 minute interval of sterilization between. Now, maybe if you just have one set of instruments or one tray, then you can squeeze some other kind of cases in between. But it's important to realize it takes about almost an hour for processing of the trays. So if you're going to be doing back-to-back or expect to do it, or there's multiple doctors doing it, you probably want two sets of trays. So the ASC will base the volume. So imagine that you approach an ASC administrator, and they're going to ask you about your volume. So two answers could be possible. One is, what's your current volume that you're performing for a certain type of case? So, for example, maybe rhizotomy for facet pain would be one. You kind of know how many you're doing, and you can sort of suggest that maybe these percent of cases would be appropriate for an endoscopic approach. Or you're kind of dealing with something that's an anticipated volume based on the number of diagnostic studies. So let me give you an example of that. The first one is easy because you know how many, say, rhizotomies you do of a certain, cervical or lumbar, something along those lines. That's easy. But what about something you're not really sure about? So let's use the example of a discectomy treating an annular tear. Well, maybe you're kind of going, well, how many of these do I really do? So you have to, if you're trying to figure out a volume for yourself, you kind of look at the patients in your practice, and you're maybe saying, well, geez, how do I evaluate this? And you might consider doing a discogram, followed by a CT scan to determine whether there's a problem that maybe could be addressed endoscopically with a discectomy. So in the beginning, you're going to do the discogram, which is not, by the way, covered by Medicare or probably any of the other insurance companies. So this will have to be done on a cash basis, and you can determine what that will be. This also is good news for the ASC because they're looking for any kind of cash inflow, particularly an ASC that might be struggling a little bit. We'll look at this even more favorably. Then once that you've determined via the discogram the need for an transfemoral discectomy, you can start to then generate a number of anticipated volume that you can give to the administrator the number of. Well, how much money is going to be going out? We've talked about money, money in. Now, how about money going out? Well, of course, different ASCs are going to have different kinds of equipment present there, but you're going to certainly need a fluoroscopic X-ray table. I'll just mention that sometimes the water use of endoscopic equipment precludes the use of some of the typical pain tables, and are more likely to use a more kind of a water-friendly, regular radiolucent just operating table is sometimes necessary. Seems to be fairly common. Number two, you need a fluoroscopic X-ray unit. The bigger, the better. So, I mean, if you have a heavy patient, you really want to have the biggest X-ray unit, the most powerful one that you can have or afford. The third thing you're going to use is an endoscopic tower, which is usually pretty common in the ASC because all the sports procedures, endoscopic knee, shoulder, etc., will be using an endoscopic tower, and there, which includes the camera and the light source and the generator for the picture, as well as the screen for the picture, which has just gotten better and better with time. The fourth item, which is very helpful, is a joint pump. Now, this allows you to put some pressure in the endoscopic equipment, which is variable, which is necessary really to help create the little bubble in which you're operating in, as well as for bleeding control. Some of the procedures require a laser, which is something that may or may not be used for urology at your particular ASC. If it's not, or it's not present, you can usually rent these for the day with a tech. And of course, last but not least are the endoscopic trays that you need to purchase to perform the endoscopic procedures. Well, how about benefits? I mean, both to benefit the physician as well as to benefit the ASC. I think that if you're just trying to get started and you're trying to, kind of fit into the community, would not be a bad idea to take a look for a struggling ASC that would benefit by offering endoscopic services. The other thing that you might consider, so the ASC benefits from that point of view. The second is that you might benefit by the ASC by considering some kind of partnership with the physicians. So if you're starting to bring in cases, you might be able to strike up a partnership of some sort with the ASC. This is probably not going to be the case with well-established ASCs that are plenty busy and don't need additional work. But with a struggling one, you might have a chance here. So if you want more information, if you're an ASC owner or a physician or an individual looking for consultation, please feel free to contact us and we'll be happy to help you. Thank you very much. Appreciate you being here. Let us know if you have any questions.
Yes, thank you so much, Dr. Morick. Let's go ahead and grab some questions. So as a reminder to folks dialed in here, you can submit any questions you have by typing them into the Q&A chat box on your webinar console. And I'm going to scroll through here and grab a question for you. So the question we'll go ahead and take now is, the attendee asks, are 10-year costs per endoscopic spine surgery case, including amortized costs for repair and replacement of instruments, et cetera, is $3,000. Medicare facility fee for 63047 or 62380 is less than that. How do you accommodate the cost versus reimbursement differential?
I might try to turn that over to Darren and see what he's got to say about that, since he's really the ASC specialist.
Thanks, Dr. Mork, and thank you for the question. Yeah, the cost on the return on this is a fine line on it, but you have to look at the other procedures that go along with this procedure that the doctors are doing, bringing in your facet injections, your different level procedures. It's just not going straight into doing the endoscopic approach or the laminectomies. It's also going into the other stuff that brings along for that patient. So yeah, it does bring into a factor of the cost of this. Yes, I understand Medicare is a lower reimbursement, but your private insurance companies usually are a higher reimbursement cost analysis. So being able to do that is what makes it profitable in an ASC. You just have to look at the complete factors of everything going into it, because this one procedure can turn into multiple procedures for the one patient. So if you have any other questions, I'd be happy to talk to you about those also.
Great. Thank you, Darren, for jumping in there. The next question we'll take is the attendee asks, as an ASC administrator, what is the most important thing I should be focusing on if I want to bring these procedures to my facility?
So I think Darren would be the perfect person to answer that question as well.
Sorry, I didn't. On that question, I'm trying to remember which question. Okay, here it is. The one thing you're really going to be looking at as an administrator bringing in these procedures is your volume ratio that's coming in versus your payer mix. That is the number one thing to look at these procedures. What are these procedures going to be replacing versus what you're currently doing? So that's really the main thing to look at to get your case mix down to the best factor in that. You're trying to replace some of your lower reimbursement procedures with these higher reimbursement procedures to override the case cost. So that's really what, looking at an administrator, you have to really break down the numbers to see if the volume versus case mix is the correct mix for your facility.
Excellent. Thank you, Darren. The next question we'll jump right to is the attendee asks, do you use the Medicare-approved endoscopic spine code 62380? That is what we've been told to use.
So there's a little cross information about some of these codes, and maybe Darren will comment because you can use different approved codes, but I think the endoscopic code is a good one. But maybe Darren's got some additional thoughts on that.
Yeah, so basically on the 62380 code, yes, that is the most commonly code that's out there for, the endoscopic decompression of the spinal cord nerve root with the LAMI. What we've actually been able to do with Dr. Mork at a few of our other facilities is we've been using more of the 63030 and the 63047. That has actually been probably more of a better play or better scenario of what's actually Dr. Mork is actually doing, depending on what he's off that. The other part into that is also doing into the partial removal of facets, either your 22100s or your 22102s. So it really just depends on exactly, you have to actually really dig into exactly what the doctor is actually doing to be able to factor in the correct code. But yes, the 62380 code is probably the one out there that everyone does use the most. But you can further define that a little bit more if you're using the other codes, the 63030 or the 47, depending on which level you're doing on that. So it's just really figuring out exactly what the doctor is doing.
Great, excellent. And the next question, we've had some great engagement here, so really appreciate it. The next attendee says, thanks you for the presentation, and then asks, what CPT codes do you use for interlaminar discectomy and transforaminal discectomy? And apologies there if I butchered any of the pronunciation, but I think you probably understand the question. So I'll throw that to you, Dr. Mork or Darren.
Right. So it kind of reflects a little bit back on what Darren was just saying. I think that the transforaminal approach can be, you can use the endoscopic code or 63056. With the interlaminar discectomy, again, you have the option of a 63030 or the endoscopic code that we've been referring to as well.
Great. Thank you, Dr. Mork, for that added clarity there.
I mean, Darren, do you have anything else to add to that?
No, exactly. That's it. It's just depending on those two codes. Basically, it's the 6330 or 6347. It just depends on if you're doing cervical or lumbar. So those are probably the two codes that she's probably looking for.
Great, excellent. Thank you both for weighing in there. And then the next question is, do you use neuromonitoring during transforaminal discectomy?
No, I've never used neuromonitoring. Really, particularly if the patient is awake, there's probably no better neuromonitoring than a wide-awake patient, or at least somewhat sedated. But I just haven't found it to be helpful. What I've seen with actually, I've had even kind of negative experiences with neuromonitoring. I was doing a cervical discectomy one time, and it was another orthopedic surgeon's dad, and he was 7T1, so it was too low to do he didn't want to do a fusion on his dad, and he didn't want to do a disc replacement, so he said, well, can you do this discectomy endoscopically from the back? I said, sure. But he was very insistent on using neuromonitoring, even though I'd never used it before. What happened was he actually kind of got a little panicked. I mean, I'm looking directly at the nerve and the spinal cord, and I mean, just as usual, no questions. We didn't have any visibility issues. There's no reason to be concerned, but the neuromonitoring was indicating that there was significant nerve damage occurring. Of course, this wasn't the case. The orthopedic surgeon was kind of beside himself, but when his dad was in recovery and kind of woke up, he just moved his arm completely normally, as I told the orthopedic surgeon that he would. But so neuromonitoring, I think, can be even a negative, even though I never use it on a routine basis.
Well, Dr. Moore, thank you so much for walking us through sort of your rationale there and that specific example. The next question we'll take is the attendee asks, most commercial payers state 62380 code is experimental and investigational. Is there a way to get them to pay, or will the patient have to self-pay?
I think that's a great question for Darren, so please take over, Darren.
Yes, so depending on the insurance company, yes, the 62380 can be considered experimental or investigational. The way we've been able to work around that when we're doing our authorizations is that we've actually been using the 63030 and the 63047 code in combination with occasionally the 62380, depending on the insurance policy. Basically, that is giving us the best way of getting around this going to a self-pay or a patient payment requirement on this. So basically, it's just on how you're doing your authorizations ahead of time and have the documentation to be able to get the correct CPT code authorized or approved. That way, it isn't considered experimental or investigational. Now, if an insurance company is really pushing to use the 62380, you can go through the authorization process and get them to override with your documentation that they will approve it. More and more insurance companies, due to the fact that Medicare does consider this a payable procedure now, are coming around and actually approving this code also, since it is a Medicare approved code. So it's just when you're getting your authorization, you just have to look at which procedure is being done, use your range of CPT codes, and go see what the insurance companies actually want on the authorization.
Excellent. Thank you, Darren. And the next question then, we've had a ton roll in, so a lot of great engagement here. So the attendee asked, should we give an estimate facility cost for the procedure considering the ASC has to run a laser and a tower, and the surgeon has endoscopic trays with the volume of patients? So should we give an estimate facility cost?
So give me the question again. So are you asking if you should give the patient an estimate or a proposal?
I think so. I believe that's what I'll read through it again and see if we can't parse out the meaning. But should we give an estimate facility cost for the procedure considering the ASC has to run a laser and a tower and the surgeon has endoscopic trays? So I think they're talking about working that in for a patient estimate. I believe that's my interpretation, at least.
Well, if that's the question, well, in my practice, I give everybody a proposal, that's accurate. And really, it does. Once we've determined it, it doesn't change. So they know what's going to happen. based on their authorization process, as well as there's an additional cost sometimes for the laser, so that has to be dialed in for the ASC as well.
Got it. And the next question that we'll take is the attendee asks, how do you cover the cost of burrs, electrosurgical costs, and loaner equipment, or do you get your facility to purchase?
So I've done both. I actually have a facility that owns the equipment and supplies everything, the electrocautery as well as the disposables that you use occasionally, like the burrs. And then I have my own trays as well in different locations. I have practices on both East Florida as well as California, so I have a little different setup in both places. And you just have to work it out with the facility. So the hospitals have a little different attitude about things than the ASCs sometimes, and then each is an individual situation, I found.
Gotcha. Well, thanks for making those distinctions. And then the next question we'll take is, what code do you use for endoscopic fusions?
So my practice, I don't do any fusions. So I can't answer that question since I don't do any fusions.
Got it.
Darren,
Okay.
Darren, do you have an information? Do you have a thought about that?
On the endoscopic fusions, I'd have to get a little bit more information on that so I could actually get you a better coding on that to see exactly which way you're going with it. I don't know one right off the top of my head that would work for an endoscopic fusion, but I mean, I could look into it. If they want to send me a message directly or whatever, I can help look into that to see what would be the best, have my coding team take a look at it to see which would be the best way to go with the codes for the procedure.
Got it. Well, thank you for addressing that and being willing to engage with folks. So the next question we'll take, again, we've had tons of great engagement. Can't say that enough. Really engaged group here. So the attendee asks, what is your estimate self-pay price for one-level lumbar discectomy or one-level lumbar decompression?
Self-pay. You mean you're talking about cash pricing for the ASC, and I think that at least in my experience, this is kind of it's negotiable. It's fairly variable. If you go to one facility, it'll be one cost. If you go to a different facility, it can vary by a couple $1,000s, to be honest. And it depends a little bit on what they're supplying to you. Are you bringing in your own instruments? Do they supply the instruments? So there's a fair amount of variation with this particular question. But so whether you're supplying the equipment or not, how much they have to supply, and it usually takes a couple of cases for them to help to figure that out as well. Darren, do you have any other thoughts about that?
I agree on that. It's basically going to be facility analysis to see exactly what the cost is going to be to build into your cash price onto there. There's, as administrators of facilities and stuff, there's a lot of different levels that go into making that cash price. Your hourly nurses, how much your estimated OR time is, recovery time, PACU time. So basically, it would be just sitting down and actually queuing the reimbursement codes and knowing exactly what your cost is for those codes to come up with a cash price. So it's really just every facility is going to be a little bit different on their cost.
Yeah, and the other thing that I'll just mention is that when you begin to do these procedures, it takes a little more time. There's just a learning curve that's time consuming, and so when you start in the beginning, you have to then look back at the time, and the ASC will definitely, keep track of this. And then as time goes forward, you might find that you're doing things quite a bit quicker, and then you can kind of help to recalculate your kind of cash pricing for a given procedure.
Great. Well, thank you both for addressing that there. And the next question we'll take then, the attendee asks, what would the volume on a weekly basis need to be to make this endoscopic procedure break even? given the Medicare reimbursement, the basis for the calculation. So what would the volume on a weekly basis need to be to sort of break even?
Well, I think I'm going to get Darren involved here shortly, but I mean, just in terms of it has a lot to do with the payer mix and also how busy the facility is. So if the facility is, not very busy, I mean, anything is going to be better than nothing. And of course, then next thing is to take a look at the payer mix. So, Darren, what other thoughts do you have?
Yeah, exactly that. It's really looking at your payer mix to see how many cases you're going to need to break even on this, but also to what is your actual cost to do the procedure for your facility. Like I said, all the facilities I work at, my cost at each facility actually is different at every facility, just because our contracts are a little bit different, our staffing is different, that kind of stuff. So it's really just coming to calculate our cost per case ratio to see how many cases we're going to need to break even on it. So again, it's going to be basically really driving down to see what it's going to cost you. And it's just not mainly just on the instrumentation, it's where you're going to calculate your cost, because you're going to amortize that over a period of time. It's actually going to be your actual day-to-day cost, your nursing, your scrub techs, all your supplies that go into the procedure to actually come up with a good case cost. So really, again, that's where driving to go into it, then factor in your case mix to come up with a kind of volume that you're going to need to make it profitable.
Great. Well, thank you both there. And questions continue to roll in. We'll take a couple more, but if we're unable to get to all of them, I know, Darren and Dr. Mork here have made it clear that they're willing to engage sort of off this platform. So the next question we'll take then, do you do surgeries under general anesthesia or on awake patients?
So for my first, since I started this, a long time ago, and I didn't always know what was going to hurt or what wasn't, or maybe even sometimes where I was, I did my first 5,000 cases under IV sedation only. So everybody was awake. But I know since then, over the past maybe 10 years, all the cases I do, with very few exceptions, unless someone's got a personal kind of maybe they're very OCD and they have a big control issue and they refuse to go to sleep under general anesthesia. I've had people fly in from different countries because they wanted to be awake no matter what. I use general anesthesia now, but that's just because I'm very comfortable with my skills and what I can do, so I'm not ever wandering around or ever wondering where I am. But in the beginning, that wasn't always the case. So I use general anesthesia all the time unless there's some personality issue these days. But initially I did. I think it's a great educational, although it takes longer for anesthesia to put people kind of at a sedation level of comfort. Particularly if they have a high drug use, that's always a tough group to anesthetize with IV sedation. But I think it's worthwhile in the beginning. And if you're wondering kind of where you are, if you're trying to enhance your skills with transfemoral discectomy in particular, I think that it's, if you're wondering if you're bumping up against the nerve, there's no better monitor than a wide awake or somewhat awake patient to tell you what's going on.
Excellent. Well, thank you, Dr. Mork. The next question then is, what is the average capital cost of endoscopic equipment?
It's variable based on what tray you're buying. So at the lower end, you've got the rhizotomy trays. Next up is the transforaminal and the interlaminar trays. And then at the top is the spinal stenosis trays. I think that the most costly thing on the trays are going to be the endoscopes themselves. And, although you might be tempted to just buy one scope, I would recommend not doing that, because if you have a scope go down in the middle of the case or it fogs up or something, you're going to need a backup scope or the case is over. So I would never try to diminish my cost by saying, I just want one scope instead of two. I think the other thing that can be done, I've seen both inexperienced physicians saying I need every other instrument, grasper, scissors, whatever on the tray, but that's actually not, that's a good place to save money, is just knowing exactly, what you need. The courses that I've published, I try to go through and say exactly what you need, so that's a good place to save money on the trays.
Great, some helpful information there. The next question we'll take is the attendee asks, what is the length of time these patients spend in the PACU?
I would say that almost no matter what case I'm doing, they spend about 1 hour, plus or minus 10 minutes.
Great. Well, thank you for that clarity there. Then the next question is, how many physicians need to have privileges at my facility on average in order for the ROI to make sense?
I'm gonna answer first, and then I'm gonna turn it over to Darren. But for me, I'm the only one at my facility who does endoscopic spine surgery. So I imagine it still works out profitably for the ASC since I don't have any complaints about it. So, but Darren, what are your thoughts?
Yeah, it can be, as like Dr. Mork said, it can be down to 1 as long as we have the case volume mix that, or the patient volume that he's bringing into the facility. Again, the more surgeons you have that are doing the procedure, you're able to spread your cost out for your equipment cost out over more surgeons. But yeah, I mean, you can do it as minimum as, you can make a good profit on these procedures by just having even just 1 surgeon doing the procedure, as long as you have a case mix on it.
Gotcha. Thank you. And Dr. Mork, I know you mentioned that you don't do endoscopic fusions, but Darren, perhaps you can speak to this question. Any cages do you recommend for endoscopic fusions?
I'm actually not a surgeon, so actually that would actually be a Dr. Mork question, or on which cages that they would recommend. I mean, I know the different cages out there that that are used, but as a surgeon, that's really their choice of which cages they want to use and what they can work with.
Yeah, that's what I've seen. Just individual preferences. People just use whatever they're comfortable or they think is the best.
Gotcha. Okay, so let's do at least one more here. So, are equipment companies open to lease agreements?
So, in my experience, I've done it numerous ways over the past maybe 8-10 years. Sometimes, and you have to approach the company and ask what you want. So I've done kind of rent to own, but I would say that most companies prefer to be approached on an individual basis. And currently, the interest rates are so low that you would almost be best to go to the bank yourself and just just get a loan and just purchase it and just take the depreciation over time. At least that's what I would do at this point in time.
Excellent. Thank you, Dr. Mork. Let's grab this final question here. So do these procedures ever turn into open procedures?
Well, I think that it depends on your comfort and skills. So, I mean, I'll be honest, I've never done an open procedure. So, I mean, I started with maybe a little, like a 14 or 16 millimeter kind of Metrix tube, and that's kind of how I got started with putting an endoscope in one of those. And then as I kind of developed my endoscopic, I bought my first, I think, transfemoral tray, I think in the year 2000 or 2001, and I've really just never looked back. So the answer, but I've never converted it to I mean, you could do it, of course, but I've just never had to do that.
Great. Well, thank you so much, Dr. Mork, and thank you, Darren, for pitching in here as well. Very, very useful, and we've had some great engagement so far. Any closing comments, Dr. Mork, for our attendees, or Darren, anything you'd like to say before we sign off here?
Well, I just want to thank you all for being here. I'm really acknowledging the enthusiasm, and I really urge you to take a look at really adopting this into your practice. I really cannot tell you how grateful patients are when you can kind of cure their pain definitively. And I think endoscopic spine surgery is just a great bridge between, what's typically offered for pain management and probably what's offered as open surgery. I think is too much, and maybe some of the pain management's not enough. So I think this is a really terrific thing to introduce into your community. And I think I'll just say that when I see a lot of my people in my kind of profession or orthopedic surgeons getting to be a certain age, they're looking forward to retirement, whereas I've kind of remained enthusiastic about this. It's not super hard. You're not in the hospital making rounds. It's extended my working career considerably, and I still remain enthusiastic about it on pretty much a day-to-day basis. So I couldn't really think of anything more than just really urge you to take a look at this kind of practice. I really enjoy it. It's been fantastic.
Well, thank you so much, Dr. Moore, for this presentation and for fielding so many great questions. It was a really engaged group. So thank you so much for that. And thank you, Endoscopic Spine Academy, for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us. We hope you have a wonderful afternoon.